All right. So again, good afternoon, everyone. And this is a review for exam 1, adult L3, NUR441. So let's start from I'm going to follow these slides, even though it's the same slides that we have from last year, but, I'm going to probably, sure, going to add more stuff. So content same, but in addition to what you have from last year recording, then will be an additional one, supplemental stuff. So let's start from with your questions first. Maybe you can start with your questions and then we'll go from there. If any has any specific question for any part of the content for exam 1.
I have a question, Professor.
Yes.
For the ABG interpretation questions, will you also be asking about compensation?
Right. Because in adult health 2, we went over this and then I believe that I covered that in the first week, I think, adult health 3, so the semester. So there will be questions pertains to compensation, full, incomplete, or absence. So full compensation, PH will be within range, and incomplete compensation, the non-matching component will be out of range. No compensation, PH out of range, non-matching component within range. I think if you list compensation, PH within range, partial or incomplete compensation, the non-matching component out of range, and then no compensation or absence of compensation, that non-matching component is within range. I believe if you write down, jot down these 3 statements or sentences, you'll be able to answer all ABG questions, because that's kind of the summary of all different types of compensations. But there will be 1 or more questions on compensation.
Professor, how many EKG strips are going to be on the exam?
Again, this is a question that is typical to the blueprint and to study guides, and the percentage of questions associated with certain chapters or content. I can't provide the answer to this question. I would say at least I would give a minimum 3. Minimum 3, can go up to, I can't tell the exact number of the EKGs, because that pertains to what's called the blueprint for exams, and we're allowed to give percentage of questions associated with content or chapters in the exam. So that's why I can't tell you exactly how many, but I can say minimum 3.
Professor, I have a
Sorry.
question.
Oh,
Any certain medications you want us to focus on?
Yeah, medications. Let's leave these questions to the end, because whatever listed in the PowerPoint slides, especially with the CHF, because there are not too many questions. Most of the, medications. Most of the medications are listed under the antidysrhythmic meds. And the antidysrhythmic medications, it's like 3 slides, which includes all the antidysrhythmic medications. The most common ones, I'm going to highlight them towards the end. But otherwise, when it comes to fluids, so we didn't have pretty much too many medications within the fluids. You have different types of fluids. The ABGs, no medications, and except for bicarb. For the mitral, valve replacements or valve dysfunctions, not too many meds. CHF, there are a few medications listed within the slides you can include, which include also, what you should include under the CHF, the antihypertensive meds. So you have all the different types of antihypertensive meds between the ARBs, the beta blockers, the ACE inhibitors, and the CCBs. And so these are the groups of medications that are going to stay within the cardiovascular system, and we have to maintain and continue talking about them, even though we did not, the antihypertensive medications was covered in adult health too. However, that when we get to the CHF and valve dysfunctions and cardiac cath and cardiac PCIs, like the percutaneous cardiac interventions. So we have to include these medications in addition to the anticoagulant medications like Coumadin, Pradaxa, Eliquis, Xarelto. These are the medications that are anticoagulant. So, and I think I explained in more details in the last year's recording or video about that. I know that we have a very safe drugs that we didn't have to do PTINR because we have Pradaxa, we have Eliquis, and we have Xarelto, but they're still are very expensive, and that's why you'll find that most people will be on Coumadin, and that's explained that why we still have to teach patients about these precautions and safety measures, and because they will be on Coumadin and doing the PTINR frequently. So the medication-related questions, you will find medications have to so related to the antihypertensive meds, medications for CHF, medications for the anticoagulation to prevent like blood clots in certain conditions like AFib and other cardiac issues, like post mechanical valve replacement. Patient will be like lifelong use of these on these anticoagulants. Medications like patients after cardiac transplantation to know all the different types of the immunosuppressant drugs. These immunosuppressive drugs are the patient's supposed to be like fully compliant with these meds. Otherwise, patient will experience the organ rejection, which is a heart rejection in this case. So that's why be on lifelong use of on these medications, anticoagulant medications like Prograf, steroids, and others, Imuran. So the other medications pertains to the cardiac cath, for example. Patients on metformin, glucophage, that should be like withheld. So to understand the relationship between this medication and the renal dysfunction in patients with renal injury. So we have to hold the metformin before and resume it a few days after the cardiac cath or any procedure in which that that will involve the use of contrast media. Other medications, I may highlight some of the antidysrhythmic towards the end, like amiodarone, and others. So that's about the medications.
Professor, I have a question about the MAP, CBP, POP, CO, CI. We have to study why, or what is the reason, or what is the meaning, what is higher, what is lower, or the nursing interventions, or only we supposed to like learn the values and how to do the formula and things like that.
No. Okay, good question. Because this is I would recommend that when you study for or read about these content areas of mechanical ventilation support, the settings and the nursing care of patients on the MVS, or intubation and mechanical ventilation support, that I'm required, I do ask you to study it conceptually to understand the process. In other words, for example, I'm not expecting yet, students at this point, this is the scope of this, this course. It's not specialty area. You are not an ICU, like, session here, or like, specialty ICU, training or ICU course, or so you will learn about these specifics when you get to the line. See you are interested in doing the ICU. You will be learning about all this specialty kind of stuff. This is more kind of advanced content. So at this point, at least to understand, I'm not asking even the difference between PPAP, CPAP, CPAP and BiPAP and all these things. The settings, there are too many settings, and it's just conceptual to understand. For example, what would be the reason for patient to be intubated and be in mechanical support? What could be some of the complications while on this mechanical support, which includes the highest or the most concerning and most significant one is like VAP, the ventilator associated pneumonia, for example. And at this point, I would like to know how or what would be the specific nursing practices and protocols to prevent the pneumonia in these patients. So in other words, that conceptually understand the whole process in terms of intubation, extubation. I'm not asking even you to list or know by heart all these criteria for intubation or extubation criteria. When would you wean them? Even though I provided you with some numbers like, the O2 or CO2 or other numbers or values, it's not, this is not the scope of this course. So to some question would be around the patient who is ABGs, like, that shows that patient is developing acidosis, for example, CO2 retention. Then what would you expect that, the ventilator setting to be increased to like, the breathing to be increased from like 6 to 10 or to 11, or you want that breathing to go from like, 12 to down to 4 or 5. So so it's more conceptual understand that we would like the hyperventilation for this patient will be great because that patient is going to blow off the CO2. So in other words, that the mechanical ventilation for this patient, the setting will go higher. So from the low to high. So that is going to fix the acidosis for that patient. Other questions pertains to the practices and nursing interventions to prevent the pneumonia. One of them, the mouth care, the practices in terms of changing the drain or the collect, like, the bottle that full of from the suctioning to be like frequently changed. There are specific like, protocol in the table in the book and other like mid-search textbooks about the tips or interventions or protocols to prevent VAP, ventilator-associated pneumonia, in patients on mechanical ventilation support. So these are the list of like nursing interventions. I would like everyone to read them and to really grasp or at least understand the intent of these practices in towards prevention or towards preventing the VAP, the pneumonia in patients on VS. Most of the questions, if there are a few questions on mechanical ventilation, it's more it will be of this type. Conceptual understand the whole process, including the prevention of complications, which includes that most concerning one, which is pneumonia. I think that's it for mechanical ventilation. Other questions?
For hemodynamics, what do you want us to know specifically for that?
Okay, if I ask question about what is zeroing or balancing, I mean, how would you accomplish a task of getting or achieving, I mean, the value of cardiac output, for example? Before you hit the button for cardiac output or any other parameters, make sure that the patient's phlebostatic access is leveled with the transducer. And that's a huge concept in intensive care units. So trying to get that value, any parameter, so PA or CVP or cardiac output or preload or afterload or any one of these parameters or these elements of the hemodynamics, you can't get the accurate, valid, accurate numbers unless you do that. So that would be the assumption that you have done that first before you get the value or measure. So to get an accurate measurement of any of these hemodynamic monitoring values or parameters, we have to do what is called the zeroing or leveling the patient's phlebostatic access to be leveled with the transducer. And that's one of the main concepts in hemodynamics. And then the other concepts hemodynamics is to understand all different test parameters, like for example, what is cardiac output, how you would measure it. So it's cardiac output equals stroke volume times heart rate, for example. A cardiac index, which is cardiac output divided by or over the service body surface area, BSA. What is stroke volume? See, these are from, I know that's from EMP and other, like, previous courses, but it's more of to reinforce it at this point, so you'll be able to understand the hemodynamics at the higher level. What is preload, what is afterload, contractility, digoxin will be part of the whole discussion here, because digoxin or and other medications that are positive inotropic medications that are going to increase the cardiac output. So that goes within the hemodynamics in terms of that patient on like with an A line on a schedule to do like cardiac catheterization this next morning, and patient on digoxin. What is the intent of all of this, or what is the effectiveness, or how would you measure the effectiveness of the digoxin? For example, digoxin is going to increase the strength of contractility, and that will result in increased cardiac output. So I would like to see that the patient in an ICU on digoxin medication or other positive inotropic medications that should result or yield or result in an increased cardiac output, for example. An increase eventually will increase the cardiac index as well. So the hemodynamic is don't expect like too many questions about it, because I know that there's this very small section, and the like, let's have almost like half a page of on the textbook, but it's just it's a critical care course, adult L3, but we have to cover some form of like coverage should be in this course about the hemodynamics. So that's all about hemodynamics. It's not a lot. Again, it's conceptual, understand it, but more of the values of or specific parameters to be understood, like what is cardiac index, what is cardiac output, what is the preload, afterload, contractility, medications that may like contribute to increase or decrease, like inotropic medications, positive, and like beta blockers, for example. Digoxin is a positive inotropic medication, will increase the strength of contraction and will result in increased cardiac output. However, that the beta blockers are negative inotropic medications, and they will result in a decrease the strength of contraction, and that will be great for a patient with angina, because patient angina, we need the intent of this given this medication is that we want to decrease the oxygen demand on the myocardium, so that will result in decreased workload, and which result in decreased chance of experiencing the angina and chest pain. So that will be great for a patient with angina, but beta blockers as a negative inotropic medications, but the digoxin is a positive inotropic medication, will be great for a patient with CHF, for example, or failure. And the expected outcome is to increase the cardiac output, so we give positive inotropic medication like digoxin.
Thank you.
Okay, sure. Any question or other questions?
Is there any topics that we should focus on more?
That's another question to the blueprint. Yeah.
Well, not really,
I
because
can't. No, I
you
can't.
said for
Yeah,
hemodynamics, you said there's not too many. So
remember that the time or the you can't look at, like, for example, if you have like 2, 3, 4 slides, and in terms of content, not like images or pictures or content, like you have two slides on hemodynamics, it includes the like, and I would say conceivably it's not I'm not saying it's not important, but at least should not be highlighted other like similar to the or compared to, for example, to CHF. CHF is a huge content area and all. Hemodynamics is a specialty, and this is just to lay the foundation, just very basic stuff. So I can't tell from the number of like time you spent on the class, or maybe like the number of slides or content included. Again, if you have hemodynamics in the mid-search textbook, it's like almost like it's like almost like a page. Means don't expect too many questions in my exam about it.
Professor, I have a question for
Yes.
the structure of the exam. I read on the syllabus that you guys are gonna start timing the questions. And if
We
you don't,
always time questions. We always time it.
So if you don't answer the question within the time that is being given,
Yeah,
it's gonna be skipped.
yes, the policy is very clear in terms of that, seconds per question. Timing, I know that even the ATI doesn't give you even way more time. That is what is stated in our policy. Our policy, we have a specific, you can go to the syllabus, and as a sophomore, junior, and senior level, it's 1 minute, like 1 minute per question. But however, that the ATI, the setting, the default kind of timing for 4 questions or time per question or second per question, and in the ATI, it does not even go by. We requested that kind of change. I think we will still give you 1.5 minutes per question, even though our policy is 1 minute per question. It's been
Okay.
We always follow the or adhere to this policy always.
Okay.
But
So-
you will have I would say, instead of one per, like this is 60 questions, you according to our policy 60 minutes, but the ATI will provide you or give you 90 minutes.
Okay. And we're not allowed to go back on the questions anymore,
No,
correct?
that's something we agreed upon from day one, and that's a faculty decision that's been made last semester.
So nothing on the exam actually changed other than we can't go back on the questions? Or is
Exactly.
the actually so nothing changed?
No, nothing.
Okay.
Yes. Okay, so I think I have a few things to go over unless you have other questions.
I have a question, Professor.
Yeah.
So, last week on the class, we were more like focused on, for the AKG, we're focused on the first, second, and third degree AV block. Is that gonna be what the exam's gonna consist of when it comes to AKG? Because that's what we were focused on in the classroom.
Okay. In Adult Till 3, we built on the EKG from Adult Till 2. So I reviewed I think it was very brief and went the other dysrhythmias. So I'm expecting that the other dysrhythmias like the sinus brady, sinus tachy, and VTAC, VFib. So that's an assumption that I would assume that you have I would say excelled or maybe you are proficient because you have completed Adult Till 2 and you are building on that foundation. So expect that to have, like sinus brady, sinus tachy, or VTAC, or VFib, or I went also over the atrial flutter versus AFib. So it was very quick review, but I can, we can do some or practice some of the EKG strips today as well. But
Okay.
no, you need to have to review all of them, including like, the sinus tachy, sinus brady, AFib, A-flutter, the VFib, VTAC, the PVCs, PACs. I went over all of that. I spent like 10 15 minutes just explaining about how would you identify the PAC in class. So it's not just the blocks, it's the blocks and the other dysrhythmias.
Thank you, Professor.
Sure. Yeah.
Professor, I have a question.
Mhm.
For hemodynamic monitoring, I was looking at different questions. So for the ejection fraction, I found out that some were like 50 to 70%, but is it 55 to 75%?
Yeah. Okay. Yeah.
Or
Believe me, whenever you see any discrepancies, like between or among, like, resources, sometimes hospitals, textbooks, and I have too many like areas of this kind of controversial or discrepancies, I would call, that I will never put a question that is going to put you like, to be confused. For example, ejection fraction. Some would say 50 to 70, others 55 to 75, or 55 to 70, or yeah. So you will find these even in lab values or like within defined limits or lab values. Same thing. I mean, some would say, okay, the creatinine is supposed to be between 0.6 up to 1.2. Other labs or other textbooks would say 0.7 up to 1.4. So as long as you are within that range, I'm not, so none of my questions will be like going, okay, so ejection fraction is supposed to be 50 to 70. So if a patient's ejection fraction. So you will never see a question in my exams. If it's 50 to 70, my question will never say, the ejection fraction 40, 55. Is that good or bad, or like this? Is it within range, or is that like poor diagnosis? Or because I know that some would start from 55, or so, or in other words, other way to say 54. What do you think? 54 is it like within range or out of range? Because I know that some people would start from 50, others from 55. So I'm not going to be in that kind of gray area to put you like to be kind of confused, because some of you will follow the Iggy textbook, other maybe Louis, others maybe like non like formal textbooks, and they go to other resources for to study for the content. So these discrepancies will never be like an issue in my exams. So I know that there are protein, like we went over this maybe in my clinical about the protein intake. Some would say like high protein for patients with liver cirrhosis, other. So these kind of areas of controversy, I'm aware of these areas. So you will never see any confusing kind of like or questions that would put you in confusion kind of state that So that's why I'm these numbers should not be of a concern, because I know that even labs, they do have some like different numbers, like they do not agree on the same values, because they use different chemical reagents. The chemical reagents they use provide them, or mandate that they have to go with some certain numbers in terms of like within defined limits or ranges. So these discrepancies shouldn't be a concern to students.
All right.
Mm-hmm.
And you're gonna give us the equations for MAP, right? And stroke
For which one?
MAP and stroke volume.
MAP, MAP is easy. Systolic plus 2 diastolic over 3. And then the cardiac output, which is stroke volume times heart rate.
Okay.
Cardiac index, cardiac output over divided by the SBA. I don't think there is any ejection fraction, also another equation. Yeah, that's all for equations for math or calculations in terms of hemodynamics. Okay, so when we say S bar, there are a few things that we haven't covered in class, but I'm just make sure that you have or have you are professionally able to answer the questions that pertain to things that we established in previous courses. So at this point, I just make sure that everyone know able to identify the S bar, right? So the S, situation, B, refer to the background, A, assessment, and R, the recommendations. Recommendations, during the recommendations, if you want to start with the situation, which is S, during the situation, part of the report, you as a nurse is going to state the purpose of calling, for example, handoff report. So if you are doing like handoff report at the end of the shift, you should be able to state the purpose of calling for that report, or why the intent of doing this report, for example. When for the B, background, so during the background part of the report, you will give the summary or brief or succinct background of the client's or patient's history and any care provided to that patient. Well, the assessment, during the assessment part of the report, the nurse will review the current assessment of the patient. So they have done this assessment of the patient. They included all the resulted in the following assessment findings. So you'll be able to provide the incoming shift with these assessment findings. And the last one, recommendations. During the recommendations, if you are giving report and you're trying to recommend anything for about that patient, the recommendations part of the report, you will include tasks, interventions, performances, things that remain to be completed or interventions to be completed for that patient so we can achieve the high quality of care for that patient. So just to address the whole process of SBAR as a systematic method or systematic methodology as we take care of patients in the hospital or especially here ICU. In terms of fluids electrolytes, I don't have like specific questions or content because I think I covered that in the other video. These signs make sure that you can identify the hypocalcemic evidence or manifestations of hypocalcemia, like the Shvastik sign and Choso sign, the potassium, hypo versus hyperkalemia. I know that it's sometimes difficult to identify from the changes or alterations in the EKG, but the most serious on EKG would be and most life-threatening is the hyperkalemia, and it easily can be detected on the EKG strip as a tall peak R wave. So that tall peaked R waves is a sign of hyperkalemia and should be identified, and corrected immediately. So the chest tube, I think we went over the chest tube in class, and we spent a good amount of time about that. The PA catheter, which is the Swan-Ganz catheter, and the waveforms associated with that, especially the PAWP or the wedge pressure or occlusion pressure, in which that we anticipate that it's towards the end right here. It's the last waveform, and we went over that in class in terms of the ranges from 2 and indicate the factors that may contribute to elevate or decrease or increase the occlusion pressure. CVP, same thing for fluid replacement, and went over that in class. And so this is the Swan-Ganz catheter, and this is and we went over this as well, right? The fluidostatic axis, and this is the transducer, and then the fluidostatic axis as being identified here. We have to look at it and the intersection between the mid chest and the fourth intercostal space. So that intersection, when the fourth intercostal space line intersects with the mid chest, that's point has to be like a mark, and permanent mark, like Sharpie, will be permanent while patient is in ICU. So anytime you're going to measure any of these or the hemodynamic monitoring measures, then we are going to level this point with the transducer. So regardless of the head of bed elevated or 20 or 30 degrees, it doesn't mean anything. It's always about, it's not the head of the bed or patient's head. If the patient is sitting or high Fowler's or semi-Fowler's position, it's always we are going to make sure that this point is leveled with the transducer, regardless of the patient's head of bed elevation level. These are just informational, these numbers. I'm not expecting that, about them. Well, I mean, to second. Okay. 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 I think we have to cover sepsis. Maybe we did not go over in class the different types of shock, right?
I'm fucking pissed. And he wasn't on. Oh, this just.
So, shock, different types of shocks and sepsis, septicemia. So if there is, I'll give you some scenarios here. A patient is admitted in the mid-surg unit, and patient's diagnosis or admitted diagnosis infective endocarditis. Patients have all different types of manifestations of infective endocarditis. So that's a let me just stop sharing because I don't have specific slides that go with this discussion. So patient admitted with this septic manifestations of sepsis or endocarditis. And the first, so what would be and when you read about the septic shock and because that septic shock has resulted um, ultimately from the sepsis and septicemia. So septic shock, to prevent that septic shock, and patient right now has the infection or admitted with this type of infection, endocarditis. So the blood cultures taken twice, you have if you are going to list certain number of or types of diagnostic testing, what would you include? Patient.
Lactic
White
acid
blood,
blood test.
white
So number one,
cell count.
I said culture, right? Blood culture.
Yeah.
What
So white
else?
blood cells.
White blood cells. Okay, CBC then, right? CBC. What else?
Would you also include like aerobic, anaerobic, and
Yeah, that
for the cultures?
right. Yeah, that will be always when you get the blood cultures, we definitely has to get like two bottles, one for aerobic, one anaerobic. So one the lead, I think this blue and red, I believe, but that you have to get like these two containers, two bottles, one filled with because both will be filled with culture or with the like with this some type of chemical. So to get one, so one bottle would be for the aerobic bacteria, another one would be so always for culture, so blood cultures, you will get like two bottles. So we will obtain. So what about the antibiotic? If you're in between, like obtain blood cultures, initiate the antibiotic IV, definitely has to be IV antibiotic, and to give the patient is like has nausea and vomiting and chills and fever and and all these different manifestations of infection or sepsis. So if you have a list of interventions, what would be the first one? So you have a list of given IV fluids, schedule like patient for EKG, obtain blood cultures, give the patient antiemetic, or let's say give patients or administer Tylenol for pain and high temp. So
Maybe fluids
prioritizing.
would be
See,
the first.
so these questions. Sorry, before you answer it, these questions you always read about the how would you prioritize, right? The interventions. Prioritization is the key towards answering most of the mid-search questions because all the options are good and they are always applicable. They are good for this patient. They are supposed to be done for this patient. All of them, almost like all of them. So it's the distractor in this case. It's not the distractor of a inappropriate for the nature of it. It's not inappropriate for this patient. The distractor here is of prioritization nature, like which one has to go first, second, third, fourth. So I'm not asking about ranking, but at least what will be the first one to be implemented among all of these interventions. So that's the way to answer the question, conceptually understand how would you prioritize these interventions. I'm between EKG and blood cultures and IV antibiotic, and I have all these different things, interventions ready to be implemented. I can do any one of them. I have the orders, I have the supply, I have the medications, I have everything. And I have the antiemetic medication, I have the Tylenol for fever, I have, and others. So just at least from the 5 different ones, which one should be the first intervention to be accomplished and has to be done first?
Blood cultures.
Either IV antibiotics.
I think IV fluid.
Okay, so we are in between IV fluid and blood culture. Understanding, okay, good. So understanding the pathophysiology of the difference between the hypovolemic shock and the septic shock. This patient hasn't developed the shock yet. It's like impending shock. Like patient is going toward, patient is still in the state of sepsis or septicemia, but haven't developed the shock yet. So to understand the pathophysiology or the difference between septic shock and hypovolemic shock. If this case or scenario was a hypovolemic shock, bleeding, hemorrhage, fluid loss, or severe diarrhea or vomiting, or the first answer always fluid replacement. Always. Septic shock, it's one of the conditions. It is patient anyway. So as I was mentioned earlier, patient hasn't developed shock yet, did not enter that phase yet. Patient is like, we have to intervene before patient develops septic shock. So septic shock means patient has developed sepsis infection. So we have to take care of the infection and not the fluid intake. Fluid intake will be significant for hypovolemic shock, not septic shock. Septic shock, your concern will be infection, to stop the infection. So number one, blood culture. So why blood culture and not the antibiotic? What about if I start the antibiotic right away, after that I take the blood culture?
You won't know what
You need to know the
Does the
affecting
antibiotic
bacteria
tell you
or
the type of
virus was.
bacteria?
It's always a wrong answer. The sequence, culture, and then IV antibiotic, always. Because that's going to skew, or maybe it will kind of sway or result in a false positive results when it comes to blood culture results. When you get the final result from the lab, the isolated bacteria in the blood culture report would be incorrect. So that's unreliable. It's not valid because we started antibiotic and then we draw the blood culture. So always the sequence, blood culture, then antibiotic. So it's not fluids because it's not hypovolemic shock or hypovolemic kind of issue. And it's not, and the blood, the Tylenol and the other anti-emetic medication that can be done right after the blood culture has been drawn. Other questions, let's say that, patient diagnosed with early hypovolemic shock. So patient had status post or survived a surgical intervention, let's say appendix, like ruptured appendix. And so if I'm going to list some nursing assessment findings, which one would be best to support early hypovolemic shock? Which one of the following assessment findings would support your diagnosis of hypovolemic shock?
Low blood pressure and then tachycardia.
So tachycardia would be always number one. Second, hypotension. Right?
Yeah.
Hypotension. Yeah. So what about the capillary refill? Capillary refill also will be
We that into second.
Yeah, exactly. And then we have the extremities would be cold from the decreased perfusion. The pulses, what would you expect for pulses to be? Distal pulses. From decreased perfusion,
it'll be low.
very weak, right? Yeah, it will be very weak. So weak distal pulses, that's from the decreased perfusion. So tachycardia how would you explain about tachycardia and hypovolemic shock? In hypovolemia, significant fluid deficit from bleeding, hemorrhage or fluid loss or GI or any. So that fluid loss resulted in that, the cardiac supposed to compensate by to increase the cardiac output. How? Because remember that the cardiac output equals stroke volume times heart rate. So the first compensation to increase the rate of the heart rate, the pulse. So the heart will beat faster to compensate to increase the cardiac output. So that would be tachycardia would be number one, capillary refill, and then cold extremities, and then weak distal pulses. Other manifestations sometimes would exist and would be appropriate for this patient. The patient may exhibit them or experience these symptoms, but it's not the specific to this. I'm sorry, it's not like the first, and it's not significant as other manifestations like tachycardia, capillary refill, cold extremities, and weak pulses. When you say uh, cyanosis. Do you think patient will be cyanotic due to this hypovolemic shock? Cyanosis has to do with the with respiration, with breathing rate, has to do with oxygenation and oxygen deficiency and oxygen supply. And so you won't expect patient to be cyanotic. So you have a list. So be careful when you answer these questions. You have a list of manifestations, but one of them will be a distractor. For example, tachycardiac, capillary fill is more than 2 seconds, and then hypotension. So far, we are good, but if we add one, cyanosis, the whole answer is incorrect. So all of them should apply to the same scenario or to the given diagnoses. Hypovolemic shock, then all of the manifestations and as one option, should all of them apply to that patient. So if one inappropriate or inapplicable to that patient, then it's just that's the distractor. So that's another example of questions when it comes to manifestations, and you will have a list of manifestations. Okay.
Wait, Professor, I have a question. I'm
Yes.
sorry.
Yes.
For the hypovolemic shock, what did you say about the capillary refill?
It's what's the normal for capillary fill?
Less than
What
2
would be the
seconds.
norm?
Less than 2 seconds.
Less than 2 seconds, right? Or 3?
So is delayed capillary fill?
Yes.
Thank you.
So
So
2.
just
You
to
go by 2.
confirm, you did mention there's no partial credit, either right or wrong. Yes.
Partial credit, we don't have. Within the ATI, the grading system, it doesn't give but we don't have that privilege or I can't even add that. It's when I would design the exam and I assign points or scores for each question, I cannot give partial credit. It's not one of the options within the template or within the system or the ATI system, grading system. I mean. Yeah. And the chest tubes, I believe that we went over titling, right? We said titling of the fluid chamber, right? Intake and output, inhalation, exhalation. So if the patient was diagnosed, for example, with anyone know what is flail chest? Flail chest? What is flail chest? Flail chest.
Is that usually when they have broken ribs and they're kind of
Yeah, that's one of the ribs or more broken, and the patient will have sort of what is called paradoxical breathing. Like when they breathe, the lungs will suck in inside, and that would be what let's call it's a serious and life-threatening respiratory condition called flail chest. So that patient, this is one of the indications for the chest tube insertion. So patient will have a chest tube for a few days. So as you observe, assess the water seal drainage, and you find there is no titling in the water seal chamber or compartment, then what would you do? What actions might the nurse take or should take to fix it? Or at least to assess. I mean, not always fixing, but at least what would be your first intervention or first nursing action, or what are the initial action taken by the nurse?
You're gonna assess the patient first.
So you have to assess the patient's breath sounds, right? Respirations.
Yes.
Absolutely, yes. So that because that patient has the chest tube for few days, and now patients the compartment as we assess, we don't see any titling. There is no movement of fluid or air, fluid going up and down or moving wavy kind of movement. So we have to assess the patient's lung sounds So in that case, we're going to determine whether the lungs have re-expanded or not, because that expansion and re-expansion. So that would be the first intervention. Because patients usually after this fatal chest, specifically, this condition or diagnosis, patients after like 3 days, their lungs will re-expand after the 3 days. So okay, another question pertains to the VAP, ventilator-associated pneumonia, and patients who has an ET tube, endotracheal tube insertion, and patient on mechanical ventilation. So which of the following like actions you would take to reduce the risk of pneumonia? Because we went over this earlier, right? About the VAP and VAP
Oral
and how
care,
to
Elevate the
so
head of
oral
bed.
care,
elevation,
Oral
head of bed
care.
elevation, oral care,
elevation of the head,
Put them on vacation, ventilation vacation.
no ventilation.
use
No, that's
sterile gloves when we
that's
suction.
yeah. The ventilation, it's not ventilation vacation. It was the sedation holiday. That's the sedation. Off sedation
Yes,
has
that's
nothing to
what I
do
meant.
with nothing to do with pneumonia. That sedation, off sedation for a while, a day or two, or I mean hours, or depends on the program or the plan for that patient. That to stop or to take the patient off the sedation. That has nothing to do with pneumonia, but it's a positive or will contribute to the patient's weaning earlier from ventilation. It may also assist in other than the weaning of from the mechanical ventilation, it will make our assessment or neurological assessment technique much easier. Because while patient on complete sedation, we cannot assess the nervous system. So the humidification of the by maintaining the moisture for the ventilator, like the tubing, there is a special container. The RTs usually take care of that. The respiratory therapist, they will change that container because that will provide some type of humidification to the patient while on mechanical ventilation. So their job is to continue, they have a frequent emptying of that container because more fluid retained in that container result in more risk for infection like pneumonia. So the tooth, oral care, that would be number one. For valve replacements, there are a few concepts here. I'll just highlight them. I believe that I went over these things in class. One of them is, for example, patients with mitral valve stenosis. So as we assess the patient with mitral valve stenosis, what would be the hallmark of mitral valve stenosis in terms of assessment findings? As you assess the patient, cardiovascular system, and you focus on the cardiovascular system, especially cardiac, what would be the most valid finding consistent with this diagnosis? When you say mitral valve stenosis, you would say patient has the following problem or assessment finding.
Autopnea.
So if you have, let's say that, if you have bradycardia, barrel chest, clubbing of the fingers, and the heart murmur.
Heart murmur.
Remember that, yes.
Epicodiastolic murmur.
Diastolic one, yes. So remember that we have a table. I'm not sure if we have it here.
Yes, we have a
right?
table.
We have a table of all different types of valve dysfunctions, and for each one we have a different type of heart murmurs. So
Yeah.
that is the hallmark of all different types of valve dysfunctions. So, and that applies to any valve, not just the mitral valve, aortic valve, or the even tricuspid, or but the most commonly like dysfunctional ones, always the high prevalence, and the prevalence is always way higher in these two valves, replacement of the mitral and the aortic valve, and that's why we covered only mitral and aortic valve, because the high prevalence is always affecting these two valves. Most people are affected by these two dysfunction or two valves in terms of valve dysfunction, mitral valve or aortic valve. We said either stenosis or regurgitation or insufficiency. So when we say clubbing of the fingers, always you think of oxygenation, breathing, COPD, emphysema, and other or even asthma. So clubbing, and that's a chronic long-term complication. Barrel chest also pertains to that COPD or emphysema or bronchiectasis or emphysema. So anticoagulants, anticoagulants. Maybe some of the questions pertain to, seems to be like more of pharmacology, but it's mid-surge because we cannot take the pharm out of mid-surge. Mid-surge means including interventions, medications, supposed to be part of the care plan, when we take care of any patient within that mid-surge content. So when we talk about the anticoagulant, and I think I mentioned that in different sessions, classes, clinical, and everywhere. Every time I talk about the AFib, I would say patients should be on anticoagulant, right? So sometimes the questions not tricky, but will be trying, okay. So I would like the student to take some steps, like patient diagnosed with, kind of in terms of thought processes, to go this kind of route. So patients being diagnosed with AFib. Okay, so I would know that patient will be at risk for thrombosis, so should be on anticoagulant. Okay, so this patient should be on Coumadin, warfarin sodium. Then the next level would be, or in terms of thought processes, that the patient should be, once we put patient on Coumadin, warfarin sodium, anticoagulant, patient should be compliant with the frequent blood work, which is PT-INR. So, and should be maintained between for AFib, we said, and other diagnosis should be between 2 to 3, except for mechanical valve replacement. Mechanical valve, the INR should be maintained between 2.5 up to 3.5. 2.5 up to 3.5. So and then the next, so we have to go that kind of, steps and and levels of thinking as you process the thoughts from diagnosis down to the INR. And now you have a question of, for example, a nurse is caring for a patient on warfarin sodium Coumadin for atrial fibrillation. You can replace atrial AFib with other diagnoses. Another question probably may ask the same question, but replacing AFib with another diagnosis like mechanical valve replacement. So the INR now is like 6.2. So the question here, which of the following medications should be administered, or at least to prep for administration, unless you have, standing order to give PRN, in case your, INR is higher than like 5.0, for example, is to give the following, to go with the following medication. Sometimes you have a PRN medication already listed in your chart, and it's already in the list of medications to give. Like when you give insulin and you give other medications, it's like PRNs. So if you have that medication PRN, which of the following medications should be? I'm not gonna, I will not provide with, list of meds, because I would like you to identify the medication yourself. So which of the following or which medication should be given, or
Vitamin
you
K.
vitamin K. Vitamin K should be always available for patients on Coumadin or warfarin sodium, because that's an antidote for Coumadin. Patient on, last week we had in clinical, we had a patient on heparin drip, for example. If you have a patient on heparin drip, for a DVT or for other cardiovascular problems, patient or PE or acute MI. So patient on heparin drip, you automatically also will have either to prep for medication, to prep for to administer, or if you have it already in your chart or record. So which medication should be available? So when the PTT or let's just stick with the PTT now. If the PTT higher than 70,
Vitamin
Protamine.
protamine
sulfate.
sulfate. So these are a question in terms of what is the antidote for these medications, like Coumadin, warfarin sodium, or heparin. I know that at St. Joe's, not to bring confusion here, is that at St. Joe's now they adopted since last year, this spring, they replaced the PTT, not completely, but for most patients on heparin drip, instead of doing PTT frequent, like every 6 hours or 12 hours, now they are doing with the anti-XA instead. Anti-XA instead of PTT. But as we speak, I mean, for our class, for the exam for mid-surge here, that we still we adopt the PTT as the parameter to monitor the heparin drip. Increase or decrease the rate of heparin drip is always based on PTT or APTT, which is active partial thromboplastin time. Active partial thromboplastin time, APTT or PTT, same thing. So heparin, APTT or PTT, antidote, protamine sulfate, and Coumadin antidote is the vitamin K. So given that we know these antidotes for each medication, we can answer the questions that pertain to the same concept, because the question is not going to say when a patient having heparin toxicity, what is the antidote? It will be a scenario to exemplify this kind of content and this kind of case study and the idea or concept of a toxicity to heparin or toxicity to Coumadin. How would you intervene? So sometimes has to be like case study format to answer these type of questions. It's not like straightforward what is the antidote for this medication.
Dr. Mikky?
Yes.
I have a question regarding the chest tube. We just say that if we don't see any titling, so that there must be something going on. We have to assess the patient. But when I was reading on the ATI book, it also says that if the chest tube was placed in the central part of the chest of following open heart surgery, that has nothing to do with hair. Bubbling and titling are not expected because it was just there after open heart surgery. It wasn't there
Exactly. Yeah. Thank you. Thank you. That's a good point. Yes. Yeah. For post cabbage, that's different. Yes. For post cabbage, that's different
Yes.
from flail chest or pneumothorax or hemothorax or other indications for chest tube placement. So chest tube insertion replacement, it depends on the indication. The only exception will be the post cardiac intervention or like open heart surgery. Post cabbage is one of them. So we're not expecting that titling to be there. Yes, thank you. So other questions about the cardiac cath. What are the most common interventions for patients post cardiac catheterization? And again, you remember that cardiac cath, it's one form of the PCI, percutaneous cardiac interventions. One of them is called cardiac catheterization, and we can do a lot around, under this kind of interventions or this area of CCI. Again, we see the stent placement, the balloon angioplasty. We can do PTCA, laser rotablation. There are too many techniques and things that we can do or interventions under that PCI. So it's an umbrella for different techniques that can be done in the cardiac catheterization lab. So the cardiac cath, the bottom line is that to understand the concept in terms of nursing care of patients pre and post cardiac cath. So we're not concerned about the specific types of procedures, if that's stent placement or if that's a PTCA angioplasty or balloon or other techniques. It's about the pre and intra and post care of patients in the cardiac cath. An example of these concepts would be let's start with the contrast media. What do we know about contrast media and the cardiac cath?
They can be renal toxic.
So patients who's renal toxic or patient has renal, I'm sorry, at the contrast media itself is renal toxic. So it's toxic to the kidneys, to any kidney, healthy kidney. So
Yes.
patients with renal dysfunction, we have options. Either you're going to select and choose the least lethal and least dangerous to the kidneys. There are different types of contrast medias and dyes. Are not there are one. I mean, some of them that are they have the least dangerous effect on kidneys. But we can also add another medication to lessen or to prevent the deterioration of kidney function. So this medication will be administered to patients with renal dysfunction. Like a patient admitted to the cardiac cath with creatinine of 1.8 and BUN is 57 and GFR of 52. So which of the following medications are going to prescribe or prepare to administer for this patient to preserve the kidney function, because we know that this patient is scheduled tomorrow for the cardiac cath, and we know that this patient will receive large amount of contrast media, and it may make the kidneys even in terms of deteriorate them and dysfunctional and may result in renal failure. So how we're going to protect the kidneys from getting worse? So
You're gonna have to give them 3 doses of Mucomis, 1,500.
Mucomist, exactly. So you have to understand the Mucomist effect of the Mucomist. You can read about the effect of the acetylcysteine Mucomist and how this medication has been proven to protect and preserve the kidney function in cardiac cath. Other medication that has to do with this scenario, metformin should be held before, right? So these two medications, to review them and understand the effect of each one and why these meds supposed to be, one of them to be like metformin to be held, and then the other one, acetylcysteine Mucomist, to be administered for patients who had some type of dysfunction, renal impairment, so we can preserve the kidney function during and after the cardiac catheterization session. The other preparations for patients like pre, intra, or post. What do you know about pre, intra, or post cardiac catheterization?
I mean, pre-post, I guess allergies. You have to ask them about allergies.
We have to ask them about the allergies, because of all the different types of contrast media, they have an iodine based, right, substance. So this iodine based, and there are some actually, there are like one or two that are non-iodine based, but most of them are iodine based. So we have to ask them about the allergy, if they are allergic to iodine.
Shellfish allergy.
Or shellfish, yes. So what about being to make sure that they are on PO or put them on PO free? The client, the patient should be on PO at least 400.
6 hours, or is it 6
Yeah.
to 8?
I mean, for the cardiac cath, not necessarily to be NPO for like 6 or 8 hours. That even the 2 hours, pre, they have to be like, because they will say they will take some time, because we didn't know if they're going to survive the cardiac cath. So during the cardiac cath, if it's just the cardiac cath, I mean, you can put them just 3-4 hours of NPO before that. But just sometimes cases during the cardiac cath, the scenario would result in an urgent CABG. So that's why they should be NPO for at least 8 to 10 hours, because we cannot guarantee that patient, that would have the cardiac cath diagnostic or interventional for a couple of hours and just go and come back or and return to the unit. Sometimes they will either rupture of the blood vessel, or patient develop some type of a acute MI, or patient develop life-threatening dysrhythmias required that we have to be taken to the OR for an urgent open heart surgery. Sometimes happens. That's why the patient should be prepped for at least 8 hours NPO before the procedure.
And I
What
also
about?
guess they have to
Yes.
stop anticoagulant meds if they taken any.
Thank you. Anticoagulant meds should be stopped before any surgery. This one and all other surgeries supposed to be held. Sometimes 3 days. Others would go even more stringent with 7 days before the surgery. So any surgery, including the cataract surgery. See how is that live? That's I mean, like it's like right the cataract surgery, and cardiac and any surgery. Anticoagulant should be withheld at least 3 days before the surgery. Now, what about post after cardiac catheterization?
Increase their fluid so that they can like wash out the contrast dye.
Exactly. We have to give them, unless they have like a condition that may prevent us from maintaining that or doing the fluid intake, encourage or push fluids to push fluids, is that sometimes they have CHF or heart failure, or they have renal failure that or liver, liver disease like end-stage liver disease, liver cirrhosis, that will prevent us from giving them the extra amount of fluids. But fluid intake will be great for a patients post cardiac cath because they will flush all that kind of contrast media, which is detrimental and dangerous for the kidneys. What about the pressure post cardiac cath? Pressure on the groin, which is the femoral side, because we access the patient adults from the groin, from the femoral, and then the children from the brachial. So groin always patient should be flat, right? Should be flat.
Yeah.
They
Yeah.
usually put a knee immobilizer on them so they don't flex their leg either.
Yes. Knee immobilizer and pressure. It's nowadays they have like the mechanical pressure devices that will create the pressure for an hour or two. That will prevent the bleeding and the ecchymosis or hematoma. So after the cardiac catheterization, you would apply gentle and firm pressure. I mean, I would say firm pressure, but nowadays we have, again, the devices, the mechanical devices, pressure devices that will exert that to prevent the bleeding or the formation of hematoma. But the most important one, before we do any of these, like the ambulation will be after catheterization. Patient should remain at least, it depends
6
on the
hours.
6 hours?
It goes from actually 2 to 6 hours. Textbooks usually go with the 6 hours, or the mid-surge textbook go by around like 6 hours post cardiac cath. So we can allow for the closure of the arterial puncture site, because the groin, we create like a small tiny puncture for the insertion of the catheter. So that will allow for the closure of the arterial puncture site when we maintain the patient's position for 6 hours flat or supine position in bed. And so the most important one post, like right after catheterization, is to assess for pulses. Pedal pulses should be assessed because remember that when we access the blood vessel, it's a large, huge blood vessel in the groin, and it may jeopardize the blood flow and the perfusion to the lower extremity. So we make sure that we assess the pulses, the pedal pulses, and of the affected extremity. If that's the right leg, for example, like lower extremity, right leg, then we are going to do the right pedal pulses to be assessed, so we can monitor for complications like thrombophlebitis sometimes results. Sometimes vessel occlusion that may eventually lead to a decrease that will be exhibited or indicated when we assess the pulses or pedal pulses that is weak, absent, or so that will be a sign of a vessel occlusion or thrombophlebitis. And that's actually, and also this is applicable to a patient with an A-line. Remember when we said, well, A-line, before the insertion of A-line, you do Allen's test and make sure that you do also the neurovascular assessment after the insertion of A-line. So after A-line insertion, you did Allen test and then A-line insertion, and then after that, frequent assessment of the peripheral pulses, right, of the affected hand. Other medications questions pertains to the cardiac catheterization. We went over allergies, right? We went about the shellfish and allergic to other stuff, and especially shellfish and iodine. We went over metformin, acetylcysteine. What is the most common complication post-cabbage?
Cardiac
CVA.
It's a dysrhythmias, right? It's one form of dysrhythmias.
AFib.
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 Yes.
AFib.
Most common, yeah.
Yes,
That's
AFib.
most common complication post-cabbage,
Yes,
atrial fibrillation. Pacemakers. Do you have any question about pacemakers?
yes, the difference between the two type. I don't know. What does it call it?
All right. So the patient who has a recently pacemaker implanted, which diagnostic test you should clarify with the nurse. If you are like, sending a patient to the hospital, or you are working in a nursing home or home setting, and you are sending somebody to do insertion of permanent pacemaker. What should you should have, like, let's say, like, you have 3 interventions or prescriptions for this patient. Which one you would clarify? And these type of questions, when we say which of the following medications, prescriptions, and interventions should the nurse clarify, what does that mean? What are you looking for?
Like,
in these questions, what you are looking for? The
like
wrong answer.
the wrong answer.
Wrong answer. So the wrong answer is something that is weird to you as a nurse, that should not be done, should not be implemented, should not be should not be performed for that patient. So if I say MRI, chest MRI, physical therapy, low sodium diet, and administer beta blocker for the patient. Let's say like metoprolol 50 milligrams for high blood pressure. So which one should not be, or at least you would clarify for them first, and then you would go from there. But which of the following? Chest MRI, physical therapy, low sodium diet, metoprolol 50 milligrams PO tablet daily.
The MRI.
Yes, MRI.
Why?
Because it
The
should be
pacemaker.
Yes. So a pacemaker, that is the MRI is contraindicated, or the pacemaker itself, pacemaker insertion, is contraindicated for MRI of the chest, or chest MRI. So the magnets in the machine, it can create electromagnetic interference and cause pacemaker malfunction. Now, what about the microwave? What would you teach the patient about microwave if they have a pacemaker insertion?
It's safe to be around the microwave.
It's safe. Yeah,
She
it's
can
safe.
use the microwave normal.
Right, exactly. So I would encourage you to go to that table and read, all these, go over the interventions, or at least the nursing care of patients with pacemakers. And one of them would say safely, or it is safe for patients to be around or to use microwaves with pacemakers. What about if they are traveling, like, and they are right at the airport? What would you teach them going to the airport?
They should carry an ID card with them that
There should
shows
be an ID card, show that they have a device, right? The pacemaker device. They have to make sure that they would know what type of, like, security, like, scanning a device to be used, handheld, and they have special buttons that should be pushed to identify that they have a pacemaker. But they at least just be informed about the pacemaker, so they can inform, right? They can, or teach them, or we teach them, so they can inform personnel at the airport about the pacemakers. So I believe I covered most of the important concepts. In addition to whatever you have or able to listen in the recorded video or session from last year. So any other questions?